Dr. Bancha from Thammasat University, Thailand. So welcome all of you. Okay. So actually we are friends. You are all friends. So please interrupt anytime. Okay. This is like a fairly course. Okay. If you have questions, raise your hand up. Also in the lab. Okay. Okay. Today we started the meniscus repair. I'm talking about the inside out meniscus repair. So meniscus injury is quite common actually. As Professor Ng said, this is a very unique tissue. Very unique. You have no graft except the graft from the allograft. So not like ACL reconstruction, you can torn many times. But meniscus, you have only one chance. So try to save the meniscus as much as you can. So the meniscus are very unique on the lateral side. Medial side is not the same. Okay, you need to know the anatomy of the meniscus also. Okay, I will not touch too much, but keep in mind, okay, medial side is quite less mobile comparing to the lateral side. And lateral side, the unique, there is a popliteus in this area. Okay, and also this area is a free zone. There's no capsular attachment. And I will tell you, this area is quite scary because behind this popliteus, from our study, the vessel is there. That's why the God make popliteus to protect you. Okay, on the medial side, we have no problem of vascular. On the lateral, keep in mind, if you're coming from this portal and you repair meniscus, in this area, behind this is a popliteus. Okay, so that's one thing that I will tell you. So what will you do in this meniscus? Yeah, cut it, right? It looks so ugly. But he's my friend. This chairman, yeah, he thought he's young, he's running Bali, and he told me, oh, Bancha, help me please. Fly to Chiang Mai to help me. So, when he got Domicum, he said, oh, Bancha, please cut my meniscus. It looks so bad. So I said, no, my friend, I need to save your meniscus. So I try my best to save this meniscus for him. Okay, we try reduction. We have the extrusion already, so reduce meniscus back using extrusion reduction. So finally, this is a picture of his meniscus. But now he's quite active. He kept getting young again. Okay, but he just told me that he had a pain on opposite side. That's 5 days ago. Yeah, on the right knee. Left knee is okay now. So first described in 1980, Henning. And this is indication for inside out. I think you need to know because meniscus inside out is a gold standard. Okay, actually it's quite good for this kind of meniscus. Middle third, posterior horn is not so good. Okay, middle third and this place bucket handle because bucket handle the meniscus keep kicking out of the joint. So the inside out is good because it's going opposite direction. You can reduce the meniscus back, okay, and make it quite anatomic. Peripheral capsular tan meniscus allograft. We use this for the inside out. Advantage is ability to treat the nearly all type of meniscus, excellent fixation, and actually is also cost effective. Okay. Disadvantage is the list of neurological structure because you need to put the needle from inside to outside. So some areas quite dangerous. I need accessory incision. Okay, and there's no difference comparing the inside out and the all inside from this article. Okay, but inside you have some problem or the nerve symptom, especially on the medial side you have the saphenous nerve in this area. Okay, that is the common complication. I will tell you the tip and tricks. Okay, for the meniscus repair. So first is the portal must be your portal must be in the joint line level. Otherwise, you cannot put the instrument in. Keep in mind, the trick is you bend the knee to 90 degrees, you palpate the lower patella. That's the area of the joint line. Okay, you go a little too high, too low, you cannot work because meniscus you have only about very narrow area to repair. Okay, so keep your portal in the joint line level. Okay, and in the inside out, if you want to repair this side, your camera must be on the same side. Your instrument coming on from the lateral, from the opposite side. Okay, The Smith Nephew, they have the meniscus stitcher repair set. Okay, they have the straight curve and also it's bendable. And there is a single lumen, also double lumen. You can use it and we can see in the lab. I show you one demonstration. This is the inside out. You want to repair on the this side. You can come from opposite side. Okay. And very important, you need to protect the needle. Okay, the way we protect the tip of the needle, see, and then pull them out. Okay, this is the meniscus inside out. Okay, and finally you make a small incision and repair the meniscus on the capsule. Okay, in case you want to repair the meniscus in the posterior horn, like this. Okay, you can make a small incision and put the protector. We always put the spoon in the back of the joint, okay, to protect the vital structure in the back. Okay, do this way. Okay, so actually you can come from nearly every zone of the meniscus repair. Okay, this is a posterior horn of the meniscus. I show you one. Okay, patient. This is the oblique tear. So in the past we did a lot of cutting of the oblique tear, but actually oblique tear or radial tear, if it's too big, like Prof. said, you get like a root tear because you lost the hook tension. Okay, or if you cut on the meniscus, the patient will have the arthritic change very fast. Okay, so we try our best. So the oblique tear or the radial tear, I prefer to use this inside out because sometimes at the body you put the meniscus at fast fix. Sometimes the patient can feel the impact. So that's I might prefer to use the inside out repair. But your stitch have to be a little bit big because if you getting too close, you cut through. Because this horizontal mattress cut is parallel to the fiber. Okay, it can cut through the tissue. So keep in mind, make it a little big. And then after that, you make a small skin incision. Okay, just really, as with the very skinny patients, on the middle side you have to be, the saphenous nerve is at least, there's two branches, saphenous, sartorial branch and infracranial branch of the saphenous nerve. Okay, make sure that your suture is not tied over the nerve. The patient will so much pain, it's like neuroma on the middle side. Okay, identify the nerve, okay, and tie on the capsule, okay, and remove all the fat tissue. So just a small incision, you take the suture later after you repair, okay. Okay, and then you tie the knot in nearly extension position. If you tie in bending position, you hold the capsule and the patient will limit extension. So recommend to tension in extension. And how to improve? You know that if you repair only one side, when the patient put the weight on, the meniscus will split under surface. Okay? Because sometimes you have very limited space because joint is so tight. You repair like mattress, that's not enough. You will need to repair upper and lower. You see? You repair upper, the meniscus will invert. And you repair lower, meniscus will reduce again. So do it in this way, upper and lower. Okay? To protect the meniscus split under surface. Okay? And another thing is like Prof. said, I did have experience about the blood clot, but I always use the KY, you see, to penetrate. You can use the diamond brass, you can use the shaver, but sometimes you cannot get like this breathing. So I prefer the simple KY to penetrate into the meniscus. You see that? There's some breathing getting out. So make sure that you have the breathing because you need a good tissue, need to fresh the tissue to promote the healing process. Okay? So we call this trephination. Very simple. Use a simple KY number 16. Okay, to make a trephination. And many times the joint is so tight. This is a trick we call the MCL release. You use the number 18. Okay, you see? After you just touch the, we call the posterior oblique, just posterior to MCL, the joint will be open. Okay, and now you can do the simple repair, very simple. Your problem of meniscus repair is you have not enough space. It's so tight. And in the past, we try to go in, you scratch this cartilage. Okay, and finally the patient have meniscus repair with condyle lesion. Okay. This is the example of one patient. He has a bucket handle tear lateral. This is very chronic, I think about 1 year. Patient cannot extend the knee. You see this double PCL sign, and also we cannot reduce. You see, very difficult to reduce this because it's chronic. And also lateral side, you cannot make a percutaneous release. You can do on medial side, but lateral side cannot, right? So the trick is you can do this inside out, okay? You start with inside out first because inside out help you to reduce the meniscus. 1 stitch, not enough. Sometimes 2, 3, 4 stitch. You see? After you pull, ask your assistant to pull the suture, and then you slowly, okay, inside out. Now I get 4 stitch already, okay, and then you start to do all inside in the back. After you reduce the meniscus, do not do all inside or fasting at the beginning because we have gap between the capsule, between meniscus and the capsule. So if you put the fasting in, you still have big gap. Okay, when you tension, it get out. Okay, try to reduce first. Okay, and do not repair at the apex. You repair at the corner first because it's closest. You know, this way like this, you repair at the anterior, posterior. Okay, close to the posterior horn. Okay, and finally you slowly. I always use this like we call high bridge. Okay, not just the inside out is not enough. Okay, sometimes you need to do all inside together with inside out. Sometimes you need to do outside in also in the anterior part of the meniscus. Okay, and finally we can reduce this meniscus back. Okay, actually it's quite difficult. Take me nearly 1.5 hours for this meniscal repair, but I think I will do my best. It's just very young. He's 19 years old and bucket handle. If you cut the meniscus, so that's the end of his knee. Okay. Now finally we can reduce this meniscus back and immobilize the knee in full extension. Do not let the patient, okay, then we open the lateral side, just a small skin incision and tie the meniscus close to the capsule. On the lateral side, that IT band, okay, sometimes on the medial side there's no IT band. Lateral side, sometimes you need to open the IT band and repair the meniscus underneath the IT band. Okay, it's quite different from the medial side. Okay, and this patient is quite lucky. 2 years after that, I performed the MRI, and it's quite healed nicely. Okay, this is 3 years. He can.
สัก3 ทีนะ
He's a police now. Okay, this is a 14 years old boy. Okay, he has a bucket handle tear the meniscus. Only 14 years old. He wants to be a professional football player. Okay? So this is his meniscus bucket handle. So first you need to make it fresh by shaver, trephination, okay? And repair the meniscus. We start from the anterior part first, okay? And then reduce this way. Very important, you should not go too high. If you go too high meniscus, you flip up like this. Okay? So stay one by one, like that. And upper surface, under surface, upper, under, in this way. Okay? Then another one. Then we go under surface, you see? Under surface. Then upper again. So Smith will not so happy because this is quite cheap. But actually, I do it combined. Okay? I do it combined. I do inside out. In the posterior part, I do all inside. Okay? But then the study, the comparing bucket handle inside out, on inside, there's no difference. Okay? But I prefer to do this way. Okay? Okay. And then, yeah, finally, in the posterior part, we do the all inside. Okay? This is a plastic 360. Okay? Upper surface, under surface. But you need space. This patient I do make a percutaneous release also. Okay? I prefer to release from the proximal side, from the femoral, not the tibial side. Okay, like that. And then we make a incision, we take the suture out. Okay, like that. Sometimes we have 10 sutures, like that. Okay? Yeah, thumbs up. Last slide. So, Okay, this patient finally, okay, he can bend the knee and he's quite happy now. He back to pray again. Okay. So last pictures. This is a bucket handle of the discoid meniscus. For the discoid, it's quite difficult because meniscus is deformed, right? So you need inside out first to reduce this discoid. You see this discoid is quite big, and also this spread. You see we cannot reduce it back because of chronicity. First we do the reduction using the inside out. Okay, like that to the capsule, like that. Okay, so many inside out, and then we trim the bucket handle. Okay, like that. Okay, shave the tissues, and then you repair. Okay, in the same technique. Like that. Okay, like that. Finally, you get the nice meniscus back again, and then we do the small incision, tie the suture on the capsule. Okay. So take-home message: inside is still the gold standard, and I think you try your best to save the meniscus, and always discuss with the patients that you try to save. But in case the patient needs second operation or it's failed, don't blame me. I try my best to help you, and don't sue me also. Do not give up to repair. Thank you.